Hello, everyone. Welcome to the workshop, Bone Health After Transplant. It is my pleasure to introduce today's speaker, Dr. Huifang Liu. Dr. Liu is a rheumatologist at the University of Texas MD Anderson Cancer Center and the co-founder of the multidisciplinary Bone Health Clinic for cancer patients. Her clinical practice focuses on optimizing bone health in cancer patients and survivors. She has done extensive clinical research in the field of bone health in patients who are hematopoietic stem cell transplant survivors. Please join me in welcoming Dr. Liu.
Good afternoon. Thank you for the organizers to invite me to speak on one of my favorite topics in the rheumatology clinical practice. At MD Anderson, we formed a multidisciplinary clinic with rheumatologists, endocrinologists, radiologists, and orthopedic physicians to work side by side to help our patients in their survivorship to improve their bone health. Without further ado, I'm going to start with our learning objectives, and we're going to work together over the next hour to address this important issue. So I want to make sure everybody understands bone loss is quite common after transplant. Clinically, after bone loss, it can lead to fractures in both men and women, and there are many risk factors that can contribute to this bone loss and fracture. Lifestyle changes is a cornerstone of bone health. I want everybody to know there are medications to treat osteoporosis and prevent fractures safely and effectively. We want to start with why is bone health important? If you could focus your attention on this normal bone, you can see there are some holes, that's our bone, but all these structures look quite sturdy. So bone loss causes healthy bone to be more porous. The pores become bigger and larger, and we call it osteoporotic. What happened is that you can visibly see that the osteoporotic bone is not as sturdy as a healthy bone. So the osteoporotic bone is more fragile with increased risk to fracture. Osteoporosis has long been known as a silent disease. What it is that it can progress undetected for many years without symptoms until a fracture occurs. The fractures can cause quite a bit of problems. For instance, spine fracture can cause severe back pain, loss of height, loss of lung volume, and a change of one's body posture. If you can see in this picture that this normal vertebral body become crushed, and you can see with time, this person's body posture will become quite, we call it a kyphosis, and the upper body will bend over. Fracture at the other side can cause inability for self-care or prolonged disability. Osteoporosis can affect the entire skeleton and is responsible for near 2 million vertebral and non-vertebral body fractures every year worldwide. Spine usually is the most common site to fracture, followed by hip and wrist, and then the other sides. Why is it important to prevent fractures? This study had demonstrated that a year after a hip fracture occurred, about 20 patients may die from complications from the fracture, such as blood clot, other issues from surgeries, or prolonged bedridden. And about 30% of patients may suffer from permanent disability, and about 40% of patients may not be able to walk independently. And there are up to 80% of patients who will not be able to carry out at least one daily activities of daily living independently. Osteoporosis is actually quite prevalent, and it usually happens to people of older age. So it affects about 200 million women worldwide, we talk about. Like 1 of the 3 women between age 60 to 70 has been diagnosed with osteoporosis, and 2/3 women will be diagnosed with osteoporosis when they're age 80 and above. About 30% of women over the age of 50 will have 1 or more vertebral fractures. And this also happened to men, but to an older age. Approximately 1 out of 5 men over the age of 50 and above would have an osteoporosis-related fracture in the remainings of their lifetime. So how does bone loss happen? We have bone resorptions and bone formation coupled as one mechanism to help us to build bones, repair bones, to fit our weight-bearing needs throughout our life. But with changes of metabolism in our body because of aging, because of loss of estrogen, and in our cancer patient because of cancer treatment, the bone resorption became too heavy that the bone formation cannot catch up. Therefore, you can see as a net result, bone loss can happen. Some of the general risk for osteoporosis and fracture is listed here. For instance, older age, female gender, previous low-impact fractures. What defines a low-impact fracture? Basically, it's not a hard hit like a hit by a car or an accident. Usually, if a person fell standing or at walking speed and sustained a fracture, we consider it a low-impact fracture. That's probably because the bone is osteoporotic, fragile, not sturdy enough. Other factors including family history of hip fracture, your mom and dad, medication that can contribute to it, most notoriously will be the glucocorticoid. We call it steroid. Prolonged steroid therapy can cause significant bone loss and fractures. And then some other factors like ongoing cigarette smoking, alcoholism, defined as everyday consuming at least 3 units of alcohol, low body weight, and some other secondary cause of osteoporosis. How do we measure the risk of fractures before a fracture happens? We have the bone mineral density study, and this has been tested in clinical settings that the numbers presented here of bone mineral density is in standard deviation, is a statistic measurement. Majority of people stay around 0, meaning right in the middle. But if you were comparing the population of your gender and your race, and then if your standard deviation is negative, going down more, and the risk of fracture goes up high. So you can see that bone mineral density is a good surrogate for us to measure how fragile or how sturdy our bones are. So DEXA scan is a gold standard for us to measure our bone health. It provides a 2D measurement of bone mineral density. It's oftentimes office-based, and we focus on the spine, hip, femur neck area, or there's measurement of total body BMD, but oftentimes we focus on the central bone mineral density. There are peripheral bone density studies. You might have been tested for your bone density in your wrist, heel, or finger, but most of those are carried out maybe at a health fair, and it doesn't represent the overall bone health as well as the central bone density measured by the DEXA scan. And therefore, if you had one of those measured, I suggest you to take the result to physicians to ask for a standard DEXA testing to confirm if you have osteoporosis. Who should get a bone density study? Remember, we talked about osteoporosis and bone loss is mostly related to aging. So the International Society of Clinical Densitometry and National Osteoporosis Foundation have been giving out recommendations basically for women age 65 and older, men age 70 and older. Also, postmenopausal women younger than 65 and men aged between 50 to 69 in the presence of clinical factors. For instance, some of the risks include very low body weight, high-risk medications. We talk about glucocorticoid, steroid, and if they already have a low impact factor, or with a disease or its treatment associated with bone loss. That would be including our patient who received cancer treatment and stem cell transplant. So patients who receive stem cell transplant are usually younger than 65 or 70. So do we lose bone? The study were conducted in late 1990s and early 2000s. Scientists have shown that bone loss occurs rather rapidly. For instance, this study has shown this is a spine that we measure, can decrease maybe by 3% after 3 months, and the bone loss in the hip area, femur and neck, which is the thinnest part at your hip area, and total hip much more significantly as compared to the spine. This is a bone loss after self-transplant, and you can see the spine actually recovered decently after 2 years, where the hip area did not improve. This is a bone loss, a collection of patients' bone density of bone loss after donor transplant at the hip area. You can see that one of the patients after about a year had near 30% bone loss, but average is about 10 to 20% bone loss after 2 years. Why do bone loss happen in people who receive a transplant? This is probably because the underlying disease and its treatment. For instance, leukemia, lymphoma treatment include steroid, chemotherapies, and some of the lymphoma treatment included radiation. In the case of multiple myeloma, myeloma itself can make holes in the bone, and treatment itself can cause further bone loss. Secondly, chemotherapies sometimes can have off-target effect. The ovaries can be suppressed so that female patient can develop premature menopause. Therefore, the bone will be devoid of the protection from estrogens. And high-dose steroid can cause men to have low testosterone, although some of them can recover later on. And we talk about chemotherapy effects, radiation. Radiated bone will lose its capacity to rebuild itself. It depends on the dosage and the time period for radiation. In graft versus host disease treatment, oftentimes the predominant medication will be glucocorticoid. And many transplant patients have severe vitamin D deficiency. In our study, we have shown up to 79% of patients, their vitamin D were low at the time of transplant. Again, with all the treatment, patient may have malabsorption. Several years ago, we did a study addressing the question, do our patients fracture after transplant? So we collected a database for patients with a total of over 7,000 that we have complete data at MD Anderson Cancer Center. In terms of self-transplant and donor transplant, the numbers are about 50-50. We find out those patients fractured, The self-transplant patient fracture about 11%, and the donor transplant patient fracture about 5%. The overall fracture rate is about 8%. Again, the location is predominantly in the spine, and there's hip and femur neck fractures in some other locations. Take a more extensive look at our 631 patients who fractured during that 14 years. We find out our patient mean age at the time of fracture were actually quite young. The patient were about 50 years old. A male patient were 55%, and for liquid tumor, we talk about multiple myeloma, lymphoma, leukemia were near 90%. Mean time to fracture from the transplant is somewhere around 2.5 years. Again, we emphasize both men and women fractured in similar rate. And vertebral body fracture is the predominant side and very similar in men and women. And you can see that longer with time, the age even play a bigger role, that if we waited, the fracture rate can go up rather high. Other than bone density, there's another tool that we can use to assess the risk for fracture. This has been established and used by WHO to predict fracture risk in the future. So you can see that age, gender, since we talk about the general risk factors for bone loss are included here. And treatment recommendation is the major osteoporosis risk higher than 20% over 10 years and hip fracture risk more than 3% in 10 years for the general population. Our group also used our database and validated that this tool can predict fracture risk rather nicely in our patient population. So if you didn't have a bone density study, but using this tool, filling up all the information that predict your risk factor is this high, then treatment should also be initiated. So when to check a bone density after transplant? At every encounter with your physician, risk factor screening should happen. For instance, lifestyle issues. Tobacco smoking should be stopped. Alcohol drinking should be canceled. And if patients have a sedative lifestyle, this should be discussed. Again, even none of this is your issue, but fragility, fall, and risk to fracture should also be discussed because cancer treatment can be brutal, that after several years, a patient can become frail, tends to fall. Also, medications that patients are taking can cause for the bone loss. A bone density should be performed 3 months after the transplant if it's already not done around the time of transplant. However, if a patient is already on prolonged high-dose steroid, then at 3 months, a bone density should be performed regardless. And bone density in our transplant patients should be repeated in follow-up every 12 months if they're on treatment to test the efficacy of the treatment, and every 1 to 2 years thereafter. So how do we improve bone health after transplant? So basically there's some cornerstones, which is lifestyle changes that take calcium either from supplement or from food on a daily basis. Get enough vitamin D that help you to absorb the calcium that you took, and start weight-bearing exercises that help to stimulate the bone to say, well, we need strong bones. And also remove clutters around your house and reduce fall risk. Keep a healthy weight because there's studies showing that muscles attached to your bone can have synergistic effect to your bone and nurture the bone to be stronger. On the opposite, if we lose a lot of muscle, we call it in a medical term called sarcopenia, which can be associated with more fall or more fractures. Again, do not drink alcohol, limit alcohol intake, and do not smoke. So basically, calcium, we recommend 1,000 to 1,200 milligrams a day in 2 to 3 divided doses, either from food or supplement. Vitamin D, if you look at the recommendation from different societies, and they talk about anywhere between 500 to 1,000 international units IU are listed here per day. It's more important to take the adequate amount to keep the serum 25-hydroxyvitamin D level, which can be measured by a blood test, between 30 to 50. And vitamin D can be taken once a day or once a week because it's fat soluble. It stores in your fat tissue, and it can be used when the body's in need. And you need to have weight-bearing exercises. Basically, you should start a personalized exercise at least 30 minutes a day. And weight-bearing impact exercise, meaning you're standing on your feet, walking, jumping, skipping, and bench stepping, will all be very helpful. So when you walk, each step carries about 80% of your body weight. So that's the easiest, safest startup for a weight-bearing exercise regimen. Resistant exercise are also important. Weightlifting, resistant band exercises, push-ups. So not to aim high, probably repetition will be safer and important. Resistant exercise can help our patient to improve your strength, your posture and balance, may reduce the risk of fall, and moderately increase your bone mineral density. I want to add a little more on calcium. We say take calcium 1,000 to 1,200 milligrams a day in 2 to 3 divided doses is because you can't absorb too much at one time. So basically, one person can absorb 500, 600 within 2 hours effectively. So we usually ask our patient to take calcium 500 to 600 milligrams at least 2 hours apart. We call it twice a day. You can take it from food, at least dairy, milk or other dairy product first, because in this country, milk product you purchase from the store are enforced with calcium or vitamin D. So consistently, of a cup of milk, which is 8 ounces, has about 300 milligrams calcium. I had a patient who started high-dose steroids, and he was a man. I started counseling about my health, and he told me he drinks 2 gallons of milk a day. Really, in his adulthood, that's what he likes. And I said, okay, continue it. And you can see that yogurt, 6 ounces, has 310 milligrams, and cheese, 1 ounce of part skimmed dry mozzarella has about 210 milligrams. And some other food who is sardines, canned sardines with bones, 3 ounces already have 325 milligrams. And salmon, canned with bones, has about 125 milligrams. And some produce, including collard greens, cooked 1 cup of collard greens has about 266 milligrams. Again, you can look at kale, bok choy, broccoli. So they average about 60 to 200 milligrams. Not as high as dairy products, but definitely are helpful and good resources of calcium that's easy to be absorbed. So when do we need medications to treat osteoporosis? One of the serious index is that if the patient fractured, especially a fragility fracture, we talk about low impact. That is definitely a definition of osteoporosis, when the bone is frail and fractured at very low impact. or if the person is diagnosed with osteoporosis by a DEXA scan in postmenopausal women or men over age 50. And we talk about that the FRAC score calculation estimated 10-year fracture risk of any major osteoporotic fractures above 20% over 10 years or hip fracture risk over 3%. What about patients with additional risk for osteoporosis? When a patient is on prolonged treatment of glucocorticoid, defined by 5 milligrams and above for more than 3 months, in our situation, it can be used for graft versus host disease treatment. So for patient age 40 and above, if the person already had a fragility fracture, again, diagnosed with osteoporosis by DEXA scan, and FRAC score, and if you can look at here, at 10% and hip fracture risk of above 1%. The lower number with additional risk factors. At age 40, we have less data. However, we knew that at any age, if a patient had a fragility fracture, their bone is frail. So the next fracture can happen. So any osteoporotic fractures occur at age less than 40, or if they have severe osteoporosis on measurement or rapid bone loss on the DEXA scan. What are the medications we can use to treat osteoporosis? And here, I'm bringing back this balance again, that we knew osteoporosis happens because they have increased bone absorption and they have decreased bone formation. So we have medication to prevent bone absorption and promote bone formation. Majority of medication tested in transplant patients are called bisphosphonates. We have oral pills and injections. Denosumab is a biologic. It also binds to the bone-eating cell, the osteoclast, which functions similarly to the bisphosphonate. I'm going to show you the summary of what has been tested in our transplant patients. All 3 oral bisphosphonates have been tested, Fosamax or Boniva. It can be taken once every week or once every month. Efficacy is moderate. Some of the side effects are if the pill stuck in the esophagus, and the person might feel heartburn, and therefore this should be changed to a different form of medication. And we need to be careful about the drug is being secreted through the kidney. If the patient kidney function is not good, then we have to consider alternatives. And we must remember that the last medication we actually did a clinical trial at MD Anderson did not have efficacy data in the hip or femur neck. IV infusion of zoledronic acid, another bisphosphonate, has been tested in several clinical trials. It is given once a year and is stronger than many other medications. A person may suffer from a body ache and flu-like syndrome for a day or two, but it's usually self-limited and can be treated with oral Tylenol or Aleve. Again, because it's a bisphosphonate, we need to check the patient's kidney function. The Prolia or denosumab is an anti-rank ligand monoclonal antibody. Therefore, it doesn't hurt the kidney. It should be given by injection under the skin every 6 months. So far, there is a clinical trial ongoing, sponsored by the company in transplant patients, and there's case report reporting the safety and efficacy in our transplant patients. If someone takes Prolia, it is a biologic. It is probably out of your body by 5 to 6 months. Therefore, the drug regimen is every 6 months. We need to be aware there's such a clinical phenomena called rebound bone loss or rebound fractures. So when this medication is out of your body after 5 or 6 months, without further treatment, the patient may lose all the efficacy and lose all the bone you have gained. Therefore, as long as the patient have a good kidney function, we followed 6 months after the last dose with a dose of reclass zoledronic acid infusion to lock in all the good effect made by the Prolia injection. But when we treat bone, we usually treat the patient anywhere between 4 to 5 years, and then when the patient's bone density is stable, we might consider drug holidays and follow the patient annually. So with such a long-term treatment, side effects should be considered. And many patients thought, I've heard bad things about these medications. I have friends or my sister took this medication and had very bad effect. So how do we decide? Like with anything, the benefit of fracture prevention in many patients who have all the risk factors actually outweighs the small risk. There is severe side effects such as the osteonecrosis of the jaw. It's very rare and often preventable. So basically, it's not the joint where you open your mouth, you seem to be cracking. Not arthritis. Actually, the bone underneath the tooth, if you have a rotten tooth pulled by the doctor, and it should heal within a week or two. But if you have been on this medication for a prolonged period of time, this healing might be delayed. Therefore, we encourage you to have very good dental hygiene, such as regular dental cleaning at least every 6 months, brush and floss every day, check with your dentist before starting the medication, and then we provide drug holidays once your bone density stabilizes after a few years. So to summarize, what we have talked about. Bone health is very important after transplant because bone loss can cause fractures in both men and women, leading to disability. There are many risk factors that contribute to bone loss and fracture. Many of them are preventable. In our actions, lifestyle changes is a cornerstone for our bone health, and there are medications that your doctors can use to treat osteoporosis and prevent fractures safely and effectively. So I'm going to leave it here for questions you may have. Thank you. Thank you for your patience and time.
Thank you, Dr. Liu, for your excellent presentation. We will now take questions. As a reminder, if you have a question, please type it into the chat box on the lower left-hand corner of your screen. Dr. Liu, the first question asks, I have osteoporosis and osteoarthritis. I am on Prolia injections every 6 months and haven't been able to find help for osteoarthritis. Is this due to transplant?
Oh, that is a very good question. You mentioned that there are two concerns. One is osteoporosis, one is osteoarthritis. Those two are two separate disease processes. Osteoporosis is the contents within the bone that can be seen and then it can fracture. Whereas osteoarthritis is a different disease process. It's regarding the joints. It's on the surface of the bone. They're unrelated. So osteoarthritis can happen with age, can happen from wear and tear, and it's also genetically predisposed. So treating osteoporosis does not affect your osteoarthritis. It doesn't make it better or it doesn't make it worse. So I suggest you to see an arthritis doctor. You can see a local rheumatologist. If it's bone on bone, quite advanced, you probably should see an orthopedic physician. So I have to say osteoporosis and osteoarthritis are unrelated.
The next question, someone would like to know about the relationship of bone mineral density and fracture risk. They would like to know if it is the same for premenopausal women, and is the relationship the same, or has it not yet been studied?
The study of fracture risks are mainly studied in postmenopausal women. Premenopausal women has the protection of the estrogen. They still have chance to repair bone, to improve the bone density. So the risk is considered less, so we don't have a clear estimate of it. But overall, people with lower bone density have higher risk of fracture.
The next question is, what value is a full body scan after transplant, and should it be done on a suggested schedule?
If you're talking about, there are two types of body scans. One is a body scan to look for cancer. We call it bone scan for cancer diagnosis. The other, I assume you're talking about full body bone density, bone mineral density, and that's not routinely performed because the correlation of the bone density centrally, we talk about the spine, lumbar spine, total hip, and femur neck, correlates with the whole body mineral density and fracture risk nicely. So that is what we use as the gold standard. So we don't routinely do whole body scan.
The next question is, I have GVHD and 8 years since my allo transplant. I had a hip replacement in 2020 due to avascular necrosis. I will probably have to have the left hip replaced also. Is this due to GVHD? I also have osteoporosis.
Well, this is an excellent question. We do see avascular necrosis happen after transplant. It's hard to separate the effect of GVHD and its treatment because if you already know from your experience that the first-line treatment with GVHD is steroid. So steroid is one of the most important causes for avascular necrosis. So we see correlations, we see association. Patients after transplant with GVHD on high-dose steroid and with low bone density, such as osteoporosis, have a higher risk of avascular necrosis. But the avascular necrosis process is similar to any other avascular necrosis. So it's hard to tell whether it's from GVHD alone or GVHD treatment. But it can be very disabling, and you could have pain and difficult to ambulate. So following a orthopedic physician, when the joint progressed to need a hip replacement, that's probably the right thing to do. And your osteoporosis should be treated aggressively to prevent fall fractures.
The next question is, I had an allogeneic transplant in 2018. I have osteopenia and I am taking alendronate. My primary care doctor and hematologist oncologist say that I can ride my horse as long as I wear a helmet, which I always do. What is your opinion on the safety of riding a horse when one has osteopenia? And they also mentioned they are a 69-year-old female. They don't smoke or drink alcohol.
Okay, very good question. I applaud you of starting a very active lifestyle after transplant. When your bone density osteopenia range, and you pretty much can do whatever activity you want to do as long as you do it safely. So if basically we want you to be cautious not to have a hard fall, not have any accident, therefore minimize your chance of fracture because fracture can happen at any age, any bone density if there's a very hard traumatic accident. So I do agree with your doctors ride your horses, be active, walk, and do it safely.
Okay, the next question says, I am 4 years past transplant and currently have mild chronic GVHD for which I take Jakafi and tacrolimus. I had osteopenia before I was diagnosed with AML. After I was on prednisone for 9 months, my bone density had declined. I had 3 reclass infusions, after which my bone density has declined even more. My endocrinologist suggests I start taking Prolia. Are there any GVHD-related reasons I should not take these injections?
A very good question. The short answer is that no. I think it's a very good alternative. You should try Prolia because it acts on the same cells as the reclass, but probably more effectively. And make sure you take your calcium, vitamin D every day and optimize dose, and added the walking exercise at least 30 minutes a day.
The next question is, what about the use of Zometa, I'm hoping I'm pronouncing that correctly, for bone health?
Zometa is another commercial name for zoledronic acid. So the company patented it as reclass, 5 milligrams once a year for osteoporosis and 5 milligrams once every other year for osteopenia. So it is very effective, and as long as the person has a normal kidney function. And if you when a person mentions Zometa, that is usually mentioned in the context of cancer treatment, for instance, breast cancer, prostate cancer, multiple myeloma, and that migrate to the bone. They use the term Zometa in a much more frequent dose, once every month for maybe 2 years. But the chemical inside zoledronic acid has been used to treat osteoporosis once a year.
Okay, what is considered long-term steroid use?
Yes, the definition has been changing, and we actually lowered the criteria. It's 5 milligrams prednisone or equivalent for more than 3 months.
Is an inversion table good for your bones?
Inversion table, right? I don't think it has beneficial effect on bone health because it's not weight bearing.
Okay, the next question is, what % does osteoporosis happen after bone marrow transplant? I had my transplant at 26.
I don't have that number down, the specific number. We have the fracture data, but it happens very often. And I'm glad to hear that you're 26. Young people, men and women, even they develop osteoporosis after transplant, they recover much better than older people. So I suggest you to continue with a very healthy lifestyle, calcium, vitamin D, and daily weight-bearing exercises. You have a good chance to regain good, healthy bone, even without treatment. But you need to be monitored.
Dr. Liu, someone would like to know your thoughts on vibration plate therapy for bone regrowth.
It is a good idea. Vibration platforms are developed by physicists who work on the mechanics of bone health. I've seen efficacy studies on elderly people. I've seen efficacy studies done on breast cancer survivors. So basically, you're standing on this platform, it stimulates your bone. That sends a signal to say this person needs strong bones. So it's not as strong as the therapeutical medications, but it's definitely a positive form, especially if you're not able to walk effectively, and use the vibration platform and make sure you do not fall, and it's a positive thing to do.
someone would like to know which type of calcium supplement is best for osteoporosis. Which type has better absorption?
Most of the calcium over the counter can be absorbed easily. I would say calcium in food is better absorbed. So I have that long list about medications, cheese, yogurt, and milk. If you can't take it, it's not a problem. You can certainly take a pill from over the counter. So most of the over-counter calcium are calcium carbonate or calcium citrate. And both can be absorbed easily. If you have, if you're a person who has acid problems, so take Tums, that's calcium carbonate. So you can try different things to see if it fits you better, but the overall are all okay to take.
You mentioned taking a drug holiday. How long would you recommend a holiday be?
So there are studies in the general treatment of osteoporosis. So we usually treat patients for 5 years. And I must say FDA had a panel discussion. There's not enough data to support or against the 5-year recommendation. But we still consider 5 years a mark. We seriously consider a drug holiday. This is because clinically we see that most patients, their bone density improvement plateaus after 3 or 4 years of treatment. So if by measurement you're not continuing to improve, you have no fractures, we want to give patient a drug holiday and to minimize the side effect. But we still measure your bone density every year or every other year to see if you drop. So there's a study showing that most people can hold the bone density 4 to 8 years after stopping the treatment. But if you started to decrease your bone density, we'll just retreat because osteoporosis and bone loss is part of aging. The mechanism is still there. We have the right medication. We just treat again. So after several years of bone drug holiday, most patients' potential side effect is much more reduced. That's why we do it.
Someone would like to know how many years do you need to get reclassed? How often should you have DEXA scans in between treatments?
The first part of the question is what I previously answered. On average, we treat about 5 years. Most patients can maximize a response by 3 or 4 years. So we seriously consider a 5 years mark and consider drug holiday. And once a person started treatment, we measure them every 1 to 2 years to test efficacy and look for potential side effects.
Okay, the next question is, I had a transplant as a kid over 10 years ago. I've recently, in my 20s, had my first DEXA, which revealed osteoporosis. Is it possible transplant caused it all these years ago? Doctor ran tests but could not identify a cause. Would osteoporosis caused by a transplant improve over time? Once diagnosed with osteoporosis, how often should one get a DEXA? Thank you.
Very good question. So transplant was one of the treatment modality you received for your underlying disease, but I assume that prior to that you also received chemotherapy or radiation or different things that might have affected your bone. So in your situation, you said at age 10, you received the transplant? So you received transplant at a very young age. You have been receiving treatments through the years that you might not have reached your peak bone density. So I would call it multifactorial, unless you're, if GVHD or transplant is one of the major reasons that it really depends on after transplant, did you develop GVHD? Did you have to take extensive steroid or tacrolimus? But otherwise, I would think it's multifactorial from the fact that the cancer treatment a young age, probably lack of vigorous exercises may have all played a role of your current low bone density. But because of your young age, you could continue to improve. You have a better chance to improve than older people with the right lifestyle changes and the help of your doctor. I'm sorry, the last part you say how often. Once you've been diagnosed with osteoporosis, that you should be followed every 1 to 2 years. So to test efficacy of everything you're doing for the bone.
Can blood work identify early bone loss?
Bone loss is defined by bone mineral density, so that that's the end result of bone loss. There are blood work can show you the work of the osteoclasts, the bone absorbing cells, and osteoblasts, the bone forming cells, but those are transient and it might not represent the long-term outcomes. So once in a while, to determine therapy, efficacy therapy, we do check the fasting early morning bone turnover markers. But as a result of bone loss, we have to use the bone mineral density to identify clinical relevance.
Dr. Liu, someone would like to know what is your general recommendation about dental implants for post-auto transplant multiple myeloma patients?
Our teeth are very important to help us how we look, how we eat effectively. So if you need dental implants, then you need to have dental implants. But if you're also on osteoporosis treatment, I would like you to have your bone doctor and your dental surgeons communicate to find the optimal time. For instance, if you're on Prolia treatment, then do it at the end of the efficacy of the Prolia injection. Do it 5 months after last injection. And then once you're completely healed, then resume your Prolia. So you need to have a comprehensive plan. But your life needs to go back to normal. If you need dental implant, you need to have dental implant. I think that helps you to have better nutrition, better health in general. But make sure your doctors communicate with each other and do it with the best timing.
Do you recommend Prolia over Reclast?
They're both very good drugs and both very effective. So we cannot predict which one is slightly better for which person. So taking Reclast didn't work well at patient, we switched to Prolia and it worked wonderfully, vice versa. So it depends on convenience, your kidney function, because one is every 6 months, one is every 12 months, and also your insurance status. So I do not have a preference. To me, both are very effective medications.
The next question asked, is hydrocortisone for adrenal replacement at 25 milligrams per day considered heavy steroid use that affects bones?
Theoretically, if you have adrenal insufficiency and you're supplemented with hydrocortisone that maintains good function, that should be considered physiological. We all have our internal cortisols, and that is not considered damaging to your bone. Only if you're over-supplemented for a prolonged period of time. So work with your endocrinologist and keep yourself as the lowest effective dose of hydrocortisone would be the right thing to do.
The next question asks, you mentioned a few medications that can promote bone growth. However, I have not seen them offered typically. Are they available, still in study, or have lots of side effects?
Oh, this is also a very good question. So in general, for osteoporosis, there are 2 drugs we call anabolics. It is self-injection every day for up to 2 years. It actually promotes bone growth. everything we talk about were about preventing bone loss. So you can see that it's more efficacious. But those medication has not been run in clinical trials. So safety and efficacy has not been well studied in stem cell transplant patients. So if all things failed, you should discuss with your doctor to see if it's worthwhile take any of the potential risk factors to treat your bone. And hopefully in the future, there are more clinical trials coming up that will be well tested in our population.
Someone would like to know, is estrogen supplementation beneficial for slowing down the worsening of osteoporosis?
In general, yes. Estrogen protects our bone. Even a small dose is helpful. But there are two concerns. Number one, you need to talk to your gynecologist. Is there any risk factor or blood clot, risk factor or any other things that you should or should not take estrogen? And second thing is that if estrogen protection after menopause is actually mild to moderate, if you already have fractures with severe osteoporosis reading on your bone densities, and then it's beyond estrogen alone.
Okay, so we are running out of time, so this is going to have to be our last question. Someone would like to know, they are 12 years post-transplant, and they had to have a bone graft around a tooth implant just last week. Is this type of bone loss related to the transplant?
Transplant alone usually does not have not been reported directly affect a piece of local bone. But again, we're talking about possibly the underlying disease, aging, and treatment of transplant consequences might be affecting. So I don't think we can know for sure at this time.
Thank you, Dr. Liu. On behalf of BMT InfoNet and our partners, I'd like to thank you, Dr. Liu, for your very helpful remarks, and thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way. Enjoy the rest of the symposium.